good afternoon, Erica Marie and Tinus.
Afternoon, Prof.
Are all good? Yeah, hi. All good for the afternoon?
I think so. I just want to check if my presentation is, yes.
Perfect. Awesome.
Okay. And you're not seeing my presenter view, hey?
No,
Perfect. Thank you so much for confirmation.
that looks good. Okay, so Prof. Zeev is also on his way.
Yes, he's on his way. Yeah.
Great. Awesome. And it,
Can I just ask, are you seeing me in edit mode or in presentation mode now?
not yet in presentation, so you still have to click on the presentation mode.
I think I'll just have to swap these around. Is that better?
Perfect.
Okay, perfect. I'll close again so that you can just put on the introductory slides for Prof.
Prof has said that he's going to share his own slides. He was quite happy to do that, but I'm here to add them if he needs help.
Great, thanks, Bridget.
Thank you.
Thanks.
Thanks so much, everybody. It's looking great. Good afternoon, Prof.
Bridget and Estelle.
Hi, good afternoon.
Hi. Please just tell me when to start, huh?
That's great.
Whenever you're ready, just tell me.
Yeah,
to-
in about 10 minutes or so. We usually wait until there's about 40 in, even if it's a few minutes after 4. And I
Okay,
see
but
we're already at 13, so it should be fine.
so once we have um more than 40 or
Yeah,
or,
around 40, then we usually go.
or 12 o'clock or 4 o'clock, we
Yeah.
start. Okay.
Yeah, and people do come in a bit later, so it's all fine if we start.
If
But
you
we will
wait.
show some signs of life before then.
Okay. Good.
We really look forward to today's. Wow, it's going to be awesome. So,
Yeah. Now let's see. Thanks. Can we start?
Yes, perfect.
Oh, good afternoon, everyone, and thanks for joining our deep dive today. We have a very exciting day lined up, and let me start by just mentioning that we'll have a case presentation from Dr. Tines Dix. That will be followed by ontogeny of macrophages and dendritic cells given by Dr. Erica Nell. And then Tines will finish off with classification of histiocytic and dendritic cell tumors. Now, the reason why this topic was chosen is that there's been a lot happening with regards to the ontogeny of these cells. And I just want to alert those who are preparing for part one and anybody else who uses the book Mechanisms in Hematology that that text is considerably out of date with regards to the ontogeny of macrophages and dendritic cells. Our first speaker will be Dr. Tines Dix, who's been with us since 2020. He is a Pretoria graduate where he got his MBCHB back in 2013. He went over to Ireland and worked as a medical officer in the stem cell transplantation service at St. James Hospital in Dublin. He did an MPhil in genomic medicine at Cambridge University. And as some of you may know, in the British education system, you've got Cambridge and Oxford and then everybody else. So we're quite proud to have an alumnus of Cambridge University among us. His MMed research, which is done and dusted, focused on myeloproliferative disorders. And I hope Tines will continue to grow in the field of myeloproliferative disorders. Dr. Dix, if you are there, take it away.
Thank you, Prof. Thank you for that kind introduction. I'm just going to share a screen. Prof, can I just check you can hear me and you can see my slides in present of you?
Loud and clear. Slides are on the screen.
Perfect, perfect. So thank you. Good afternoon, everyone, and thank you for this opportunity. As Prof alluded, today's topic will be on macrophages and dendritic cells, which I think becomes quite a nebulous topic for a lot of us after we think about the cells themselves. We have a vague idea about their function and their role, but after that, I think it becomes a little bit more difficult because these diseases are tumors, at least, of these cells are relatively rare. However, the WHO, definitely in its authorized and its fifth edition, saw fit to give these diseases their own chapter, so it must be important to us as hematologists as well. So perhaps a good place to start to just ground our understanding a bit better would be in a case presentation. So this is patient ZN. She is a 2-year, 8-month-old female. When she presented initially with right orbital swelling, she had a fall a few months previous, and the parents kind of thought the swelling was related to the fall. However, there were some other symptoms that were worrying during this time. So she had proptosis of her eye, headaches and fatigue, but no associated vomiting or any cranial nerve fallout. And she also had a scalp seborrheic dermatitis that was noted. Other features that were worrying were loss of weight, hepatosplenomegaly, and lymphadenopathy. A PET CT scan was ordered, and this showed enhancement, so increased uptake on the marrow, the spleen, and the skull around the area of the orbital swelling. And then a biopsy was taken of the primary lesion. A bone marrow examination was also ordered at that stage. with an FBCN film that showed a microcytic hyperchromic anemia. There was an associated low ferritin, so this was deemed to be an iron deficiency anemia. And then on the bone marrow aspirate, she didn't have any atypical cells. However, if we move over to the trephine examination, you can appreciate that there is disruption of the normal architecture. What's quite prominent are these large cells with voluminous pale eosinophilic cytoplasm. And if you compare them to something like a normal megakaryocyte, which you can see here, the megakaryocyte seems to be quite, how can I say, well circumscribed borders, seems to be quite well behaved. And these other cells really are invaginating between the normal hematopoietic tissue. You can also see some eosinophils here making up the inflammatory background that accompanies these cells. And if we look here on the right on 100 times magnification, you might be able to appreciate how strange the nucleus of these cells look. So a bit of a reniform kidney-shaped nucleus. And if you look carefully, you might be able to see a groove or indentation in the nucleus of these cells. So immunohistochemistry was ordered. These cells were positive for CD1A, positive for S100, and positive for CD207. This was enough to make a provisional diagnosis of long-around cell histiocytosis, and this was also confirmed on the biopsy result that was taken from the eye proptosis. Because of the involvement of the marrow and the spleen, the patient had a splenomegaly, this was deemed a high-risk long-around cell histiocytosis, and there was a risk for CNS disease due to close proximity to the brain. So the treatment course of this patient, she was started on long-around cell histiocytosis 3 protocol. So the first course of this protocol involved vinblastine and prednisone for an overall period of 6 months. However, after she completed 6 weeks of treatment, she had an interim PET CT done, and this showed no metabolic response, unfortunately. Before the result of the PET CT had come out, she had already started on her second course of LCH3, and at this stage, methotrexate was added to the protocol because she showed clinical progression of the primary lesion and proptosis that was getting worse. She was deemed to have refractory disease at this stage and was initiated on salvage therapy. There was motivation for cytarabine and cladribine to be started in this patient. She completed 5 out of 6 cycles, but after the 5th cycle, she showed severe myelosuppression, bruising, and pneumonias, and it was deemed too dangerous to continue with the cytarabine and cladribine. However, she did show a partial response after this therapy. Finally, she was given etoposide, 2 cycles, and I'm happy to report that she finished the etoposide now 7 years ago. She's alive and well and attending school currently. Right, so with that case out of the way, I'll hand over to Dr. Nell, who will take us further.
While Erica is changing the slides, I just want to remind one and all that if you have any query regarding the mailing list, please email Melanie Davids, and also please don't forget to do the feedback at the end. We'll try and have question and answers off the floor, but if you have a burning question or if you're forgetful, just type it in the chat and we'll try and read it out to the presenters. Erica?
Thank you, Prof.
I would like to, I haven't spoken about you yet.
Sure.
I would like to introduce Dr. Erica Nell. Erica is a Pretoria University graduate from, sorry, man. So my apologies, Pretoria. No, definitely not. She's from Wits, where she graduated in 2014 and did a registrar training here at Tygerberg. And in that period, she studied hard enough to get an M.Med cum laude back in 2021. She also has a Master of Science from the University of Cape Town from 2010. With a background in science and genetics, she's got a very serious interest in research. And, you know, the results are showing, since she started with us, she has published 11 papers, of which she first authored 7. And I'm particularly proud of that aspect of Dr. Neo's career. Back to you, Erica. Sorry, I interrupted to introduce you.
Thank you so much for those kind words. I do indeed enjoy some research. Okay, so but today we are not going to talk about that. We're going to talk about macrophages and dendritic cells and see what we can learn from the ontogeny. So what we're actually going to talk about today is the mononuclear phagocytic system, or the MPS. And this is a better name for the reticular endothelial system. So the RES was originally coined to denote a system that removed vital stain. So they administered vital stain into a vertebrate, and they kind of saw where did the stain go, and they called this the reticular endothelial system. But since then, we've actually learned that there are cells that are responsible for removal of most of the foreign bodies and dying cells, and these are the macrophages and dendritic cells. And so the MPS was already proposed in 1969 as a more accurate term by these scientists and doctors, Cohn, van Firth, and Hirsch. And our textbook, Williams Hematology, states that RES is an obsolete term. It states this in the dendritic cell and macrophage chapter, but then in other chapters of Williams, they still refer to the RES. So it seems like hematologists in general aren't really like big into catching on that we're moving on from RES to MPS as a definite term. But certainly for all of the articles that I read in preparation for this deep dive, all of those articles refer to the MPS. So MPS is in and RES is out. Another term that I just want to clarify quickly is the term histiocyte. So again, Williams Hematology states that, that macrophage is synonymous with histiocyte, but it also acknowledges that histiocytosis is used to denote conditions pertaining to both macrophages and dendritic cells. And another source stated that a histiocyte, meaning tissue cell, should be used only for macrophages that are resident within tissues and not macrophages that are newly recruited for like an inflammatory response. So what we can tell from this is that different people have different definitions of histiocyte, and when you say histiocyte, it might not be the same as what your audience knows as a histiocyte. So it's important to just clarify what you mean when you're speaking about histiocyte. But let's talk about macrophages and dendritic cells. So macrophages are large vacuolar cells, and their main function is clearance and phagocytosis of apoptotic cells and cellular debris and pathogens. And they are identified in studies by this marker F418. It's relatively well conserved in mice and in humans, therefore they use this in their studies, even though we don't use it on flow cytometry. Then for dendritic cells, these are stellate cells, and their main function is to present antigen on MHC molecules and migrate to lymph nodes where they activate T cells. And they are identified by CD11C and MHC2. However, alveolar macrophages express CD11C, and intestinal macrophages express MHC2, and those macrophages are expressing dendritic cell markers. Additionally, plasmacytoid dendritic cells, they express PDCA1, but this can also be acquired by monocyte-derived cells during inflammation. And the inability to consistently identify myeloid cell subsets, irrespective of the tissue or the inflammatory state, makes this an unattractive base for classification and can lead to some confusion. So what about ontogeny? I just want to take a step back to what Prof alluded to when he introduced us, and he said that what we read for primaries, at least as hematopathologists, is the first textbook we go to is this online textbook, Mechanisms of Hematology, because it's a relatively easy and simplistic way in describing hematology to us. And in chapter 16 here in dendritic cells and macrophages, it speaks about dendritic cells being coming from monocytes, which are coming from bone marrow stem cells. And later on in the rest of the chapter, it also states that macrophages come from monocytes. But I'm going to show you how much our understanding has developed since this was published in 2010. So the original MPS model proposed by Cohn, van Furth, and Hirsch showed that monocytes, or proposed that monocytes were the origin of macrophages and dendritic cells. And this is the same as what was stated in our mechanisms textbooks, that macrophages and dendritic cells come from monocytes or from the bone marrow. But what was soon discovered after that was this common dendritic cell precursor. And this posed a problem for this classical MPS model, because dendritic cells were now not arising from monocytes, but were instead arising from this common dendritic cell precursor. And this was the first amazing revolution in the field. And moreover, they discovered that FLT3 ligand, rather than DMCSF, was critically involved in the development of the conventional dendritic cells. Then the second conceptual revolution in the field was the discovery that resident macrophages don't derive from bone marrow, but actually derive from embryonic precursors. And so that was like a what moment, and we really had to rethink about how we are classifying these cells. So the relative contribution of yolk sac macrophages and fetal liver macrophages varies from one organ to another, but even the fetal liver macrophages are derived from yolk sac macrophages. And this really challenged our dogma that dendritic cells and macrophages are derived from hematopoietic stem cell or bone marrow derived monocytes. So altogether, this suggests that the cell of origin may be a better way to classify cells in the MPS rather than function or phenotype. And it results in three big groups. So the first group is the embryonic derived macrophages. The second one is the common dendritic cell precursor derived dendritic cells. And then the last one are the monocytes. And the latter two of these are bone marrow or hematopoietic stem cells derived. While monocytes can take on the phenotype of a macrophage or a dendritic cell, in the steady state, we can now relatively easily distinguish populations of dendritic cells from the dendritic cell precursor and from the monocyte. And this new ontological classification does come with some caveats. So most of our understanding comes from cell culture or protocols of patients with mutations that had mutations in genes for dendritic cell or macrophage development. And most of these precursors are first identified in mice, and then we look for a corresponding cell in humans. So there's still inherited biases, and the complete picture is still incompletely described, but at least we are getting to understand these cells a bit better. And an example of this is in this different schematic. Some of the differences to highlight here is the plasmacytoid dendritic cells, where in this schematic we can see that they can come either from a common lymphoid progenitor or that common dendritic cell precursor. And they also in the schematic showing that embryonic precursors are responsible for macrophages, but they're keeping macrophages and Langerhans cells separately, and also showing a contribution to macrophages and Langerhans cells by monocytes. One dendritic cell that I haven't mentioned yet are follicular dendritic cells. And the reason for this is because these are mesenchymal, they come from a mesenchymal stem cell. So follicular dendritic cells are found in the germinal center of secondary lymphoid organs, where they're responsible for activating B cells. So follicular dendritic cells are not interacting with T cells like our other dendritic cells, but these are responsible for B cell activation. They also don't process antigen like dendritic cells, and they don't have MHC2 molecules. And very importantly, they don't originate from the bone marrow. So rather, these follicular dendritic cells, they capture antigen onto their Fc receptors and their complement receptors, and then they decorate themselves with these whole unprocessed antigens. And they've kept the dendritic cell name because of their appearance, but they are not hematological cells. So let us speak about our hematological dendritic cells. So initially, dendritic cells were divided into lymphoid and myeloid groups, but this didn't accurately reflect the ontogeny of dendritic cells fully. So then different authors were all classifying their dendritic cells according to their organ that they were interested in, and this resulted in multiple different subsets of dendritic cells all being described separately in different organs, and there were loads and loads and loads of dendritic cells to keep track of. But then we had now this evidence of this common dendritic cell precursor, and that means that regardless of what organ it's going, it must come from a certain place. So there we go. So then based on gene expression profiles, the dendritic cells were divided into 4 subsets. And this had a relatively good correlation with function. So the plasmacytoid dendritic cells, they were interferon type 1 producing cells. The conventional dendritic cells 1, those were the ones that were good at cross priming. Conventional dendritic cells 2, those were the T helper cell priming dendritic cells. And then those that were monocyte derived were important for inflammation. And these 4 categories all have their own transcription factors, and they all have their own surface markers. And importantly for us, because we look at blood, they named these blood dendritic cell antigen, or BDCA. So they were named because they were particularly useful in distinguishing dendritic cells from monocytes. And the plasmacytoid dendritic cell ones are BDCA2 and BDCA4, which are CD303 and CD304. BDCA3, which are in the type 1 conventional dendritic cells, that's CD141, and BDCA1 of the conventional dendritic cell 2, that is CD1C. So a little bit more about plasmacytoid dendritic cells. So they are the interferon-producing cells and therefore involved in viral immunity. Their morphology resembles plasma cells, but their development correlates with conventional dendritic cells. Additionally, it's been shown in vitro that they can assume a dendritic cell appearance and they can influence T cell fate, and therefore we are happy to keep these cells in the dendritic cell category. Their main transcription factor is TCF4, so this is the master regulator of plasmacytoid dendritic cells, and as I mentioned, they express CD303, 304, and CD123. CD123 is interleukin-3 receptor alpha. But there are some pitfalls and cautions to be aware of. The one I've already alluded to is that could there be a common lymphoid progenitor that is responsible also for producing these plasmacytoid dendritic cells? This data comes from recent data in mice, which indicates a sole lymphoid origin for plasmacytoid dendritic cells. But it hasn't really been demonstrated in humans whether there can be a lymphoid origin of these cells. And the second pitfall to be aware of is how they came up with the idea that plasmacytoid dendritic cells can influence T cell fate. And the problem there is that pre-conventional dendritic cells have almost exactly the same immunophenotype as plasmacytoid dendritic cells. So it might be in these cultures that there's contamination by conventional dendritic cells, and it's actually them that was responsible for T cell stimulatory capacity and not plasmacytoid dendritic cells. But this is still speculative and it's early days, and we shall see how this evolves. One of the authors suggested that they can come up with a beautiful hematological tree to show how plasmacytoid dendritic cells can have a lymphoid or a myeloid origin. And they suggest that this common lymphomyeloid progenitor. So this is very different to the classical way in which we see hematopoiesis. Very early on in our minds, we have a lymphoid and a myeloid progenitor, and they are separate. But in this model, we have the erythroid and megakaryocytes that are branching off very early. But then the lymphoid ones are kind of hanging around for quite a long time, and only very late we have the B, T, and NK cells branching off. So other things that are a little bit different from our conventional way of knowing things is that the neutrophils are sitting on this side compared to the eosinophils and basophils, which in this tree are more closely related to erythroid and megakaryocytes. So there's lots of interesting ways in which this is evolving, and maybe what dendritic cell ontogeny is allowing us is to rethink altogether how hematopoiesis is coming about. So the next subset of dendritic cells is the classical or the conventional dendritic cells, CDC, and these can be subdivided into CDC1s and CDC2. So the CDC1s, they express XCR1, which is a chemokine receptor, and they are known by their transcription factors IRF8 and BATF3, and they are involved in differentiation of naive T cells into cytotoxic T cells and T helper 1 cells with the CDC1 cytokine interleukin 12. And if we remember, these are the dendritic cells that are capable of cross-presentation. So they're able to process antigen on both MHC1 and on MHC2. And this is different from the CDC2 dendritic cells. They are known by their transcription factors IRF4 and KLA4, and they express CD11B, and they produce T helper 2, T helper 9, T helper 17, and T regulatory cells, depending on the inflammatory milieu and the cytokines that they produce. So if we take these dendritic cells that were described for each of the organs, we can now categorize them into dendritic cell 1s or 2s. And so, for example, in the lung, we have the CD103 positive ones. So these CD103 are CDC1s versus the 11B ones over there, which are CDC2s. Similarly, in the spleen, this green population expressing CD8 alpha are CDC1s, and those ones that are expressing CD4 are CDC2s, and so on and so forth. And so we're getting a better understanding in each of the tissues or each of the organs. What about the monocyte-derived dendritic cells? So they have a completely separate progenitor from the common dendritic cell precursor. They have this common monocyte progenitor. And the function of the conventional dendritic cell is very different to the function of the monocyte-derived dendritic cell. Like conventional dendritic cells, the monocyte dendritic cell expresses 11C and MHC2. But unlike the conventional dendritic cells, they are not good migrators. They don't migrate to the lymph node and therefore activate naive T cells, but rather they're involved in the local inflammatory response. But there are some complexities of dendritic cells to be aware of. So I mentioned earlier about the lung and how CD103 is dendritic cells 1 and 11B is conventional dendritic cells 2. But then during inflammation in the lung, we have 4 subsets that can be seen, and not like the 2 original. And moreover, those additional subsets are transient, so they're only there during the inflammatory response. So we have to wonder what are these additional subsets? There's 2 options. One, these are new dendritic cells that are arriving from the bone marrow during inflammation. So they're either monocyte derived or conventional dendritic cells derived, but they're coming from the bone marrow and they're new. Or the alternative is that they are resident dendritic cells that in the inflammatory milieu are acquiring additional surface markers. And in this review article, they mentioned as unpublished data that they have experimentally proven that this orange population expressing both CD103 and 11B are actually the green population, CC2s, that have acquired 103. So let's move on to some macrophage ontogeny. All mononuclear phagocytes of the embryonic origin are macrophages. And historically, we named macrophages based on their location. So we called Kupffer cells, the macrophages in the liver were called Kupffer cells, and in the brain, they're called microglial cells, and in the lung, alveolar macrophages, and in the epidermis, Langerhans cells. And this is really, really interesting because Langerhans cells were always described as dendritic cells. But because they are derived from these embryonic precursors, we can say with somewhat certainty that Langerhans cells are macrophages. And I will carry on talking about Langerhans cells at the end of this talk because I think it's important. But there's a lot of development in this area. But now, before we move there, we're going to talk about these resident macrophages. And this is where the third key recent finding in our understanding of the MPS took place. And this was that resident macrophages that came from embryonic macrophages into the adult tissue are able to persist and have stable populations. So they were capable of self-renewal throughout adult life, and they did not need the bone marrow to supply them with additional macrophages. So all of these cells that are listed over here, all of these macrophages, are all capable of self-renewal and are stable within themselves. They don't need the bone marrow. By contrast, there are some other tissue-resident macrophages that do rely on the bone marrow to be replenished. That is the dermis of the skin. Note that the dermis of the skin is different from where Langerhans cells are found, the epidermis, as well as the gutted and interstitial lung. And important, these bone marrow-derived macrophages, their main function is for increased demand in infection and inflammation. Importantly, bone marrow-derived macrophages are not capable of self-renewal. They are short-lived. There are some intricacies to be aware of. So not all macrophages in the brain are microglia. So we have a steady state microglial cell over here, but then we can see that during inflammation, there can be leaking of these monocyte or macrophage-derived cells into the brain parenchyma, and these cells do not look the same as the microglial cells. They do not have the same gene expression profile, and they are also short-lived in contrast to the microglial cells. Similarly to that, not all macrophages in the liver are Kupffer cells, so macrophages that infiltrate the liver during paracetamol-induced injury have a different gene expression profile to the resident Kupffer cells and are short-lived. So this brings up an interesting dichotomy, or that maybe we shouldn't be referring to infiltrating cells by their historical name. So keeping it separate, that a microglial cell is different from a macrophage that's infiltrating the liver, infiltrating the brain, for example. And then the other cells we're going to talk about is these monocytes that have really amazing plasticity. So monocytes that are cultured in CSF, they express dendritic cell-like characteristics and so-called monocyte-derived dendritic cells. And if we culture them in mCNS, then they go into macrophage morphology. So if we add interferon, then we are classically activating these macrophages, and these ones are M1 macrophages that are specialized in pathogen killing. And if we add interleukin-4, then we call this alternatively activated. And these are M2 macrophages, important for tissue remodeling. But there are problems with this model. So while polarization might be achievable in vitro, in the body it is really challenging, and monocytes can acquire a much broader transcriptional repertoire. So on the right-hand side, here's an example of an inflamed mesenteric lymph node, and we can see here the blue is showing actin. So actin is very important for phagocytosis. We can see on the red here this MHC2 expression, and we can also see the dendritic morphology of these cells. Additionally, they express 11C, MHC2, CD64, and F880. So one set of authors called these macrophages based on their phagocytic ability, their F480 and their 64. And another set of authors called these dendritic cells based on their CD11C and MHC2 expression, and the fact that they were localized with T cells and had antigen-presenting capacity. So, although one can argue that naming is arbitrary and unimportant, as it has no bearing on the function of the cell, it becomes a concern when there's poor consistency between laboratories and leads to assumptions and biases. And has the cell been described before, and it can lead to miscommunications and confusions. And there we go. So fundamentally, we know that all of these cells were derived from monocytes, and putting them into a dendritic cell or a macrophage box may be artificial. As such, there's a need to identify these cells as monocyte-derived. And that will allow us to understand that there is a plasticity on the macrophage dendritic cell spectrum. So in general, the monocyte-derived cells orchestrate local inflammatory response, being that phagocytosis of apoptotic cells, or pathogen cleaning, or cytokine release, or tissue remodeling, but it's a local response, and they are generally not migratory. And this is in contrast to the conventional dendritic cells. And this has importance for implications of dendritic cell-based vaccine strategies. And it is one of the hypotheses why monocyte-derived dendritic cell-based vaccines have previously failed. So while monocyte-derived cells have great plasticity, depending on the environment, the individual cells are not plastic. And terminally differentiated macrophages will not be able to change their immunophenotype. For example, they can't no go be bone marrow macrophages. Those are the important things to realize with monocyte-derived cells, be that they look more like dendritic cells or more like macrophages. The last cells we're going to talk about are the Langerhans cells. And as I mentioned in the beginning, they were described as macrophages based on the fact that they are originating from the yolk sac precursors or embryonal precursors. But for example, in this schematic, we see they can both come from embryonic precursors, and there's this little dotted line to suggest that monocytes can become Langerhans cells. And in a different group of people, again, they acknowledge this embryonic precursor as a Langerhans cell precursor, but they are now suggesting that the conventional dendritic cell is the source of this of the Langerhans cell and not the monocyte. So there's still some unanswered questions as to what exactly is going on, but let's look at a little bit of the intricacies of why this is happening, and we'll discuss the dual identity of Langerhans cells. So Langerhans cells are migratory myeloid cells that are located in the epidermis and the mucosa. And there are other cells inside the dermis. They are not Langerhans cells, even though they are dendritic cells and they express Langerin or CD207. So Langerhans cells, they express Langerin and CD1A at high levels, and they also contain Burback granules, which we can identify under electron microscopy. So importantly, and the reason that we think that they are macrophages is because, one, they come from these embryonal precursors, but also they are capable of self-renewal, like all of the other embryonal-derived macrophages. Unfortunately, they also like to act like dendritic cells, so they migrate to the lymph node when activated to go activate naive T cells. And if we look at the transcriptional profile of Langerhans cells, then their transcription factors are both of macrophages and dendritic cells, possibly skewed slightly towards the dendritic cell profile, but we're still very unsure exactly what it is, and there's still debate in the literature as to what these cells are. Importantly, this capability of self-renewal has been confirmed by limb transplants and bone marrow failure syndromes. So we know that Langerhans cells are definitely independent of the bone marrow and can and are self-sufficient. So where does this confusion come about, like where Langerhans cells are coming from? And we know that circulating mononuclear cells are able to acquire a Langerhans cell-like phenotype. So during skin inflammation, the Langerhans cells will migrate to the lymph nodes and go present their antigen to the T cells. And then we have these cells that are coming from the blood that go into the epidermis, and they are expressing a Langerhans cell-like phenotype. And these are bone marrow derived, and they are short-lived. So the Langerhans cell population is ultimately still self-reliant on these epidermis resident Langerhans cells to self-renew and maintain the populations. Those ones that came from the blood, they are only there during inflammation, and then they die thereafter. So These cells that come from the bone marrow, what are they? So some people have described them as monocytes because we've been able to culture monocytes, and then they take on a Langerhans cell phenotype. But there's also other groups who say that these cells are coming from conventional dendritic cells because they have found that they express BDCA1, which is the conventional dendritic cell marker. So whether the Langerhans cells indeed have a dual identity of both macrophage and dendritic cell, or both embryonic and bone marrow derived, or whether they merely have been mistakenly identified due to our limited knowledge of the plasticity of circulating monocytes into Langerhans cell-like cells has yet to be clarified, but the science is getting closer to our understanding of the truth behind the Langerhans cells. So in conclusion, I hope that I've shown you that monocytes are not the only axis of the MPS system, and that we have long-lived tissue-resident macrophages, and we have a specialized dendritic cell lineage that contributes to the tissue mononuclear population. Lastly, it appears that resident tissue Langerhans cells are probably better described as macrophages, and that short-lived bone marrow-derived cells are able to take on a Langerhans cell phenotype, be that monocyte-derived or common dendritic precursor-derived. And this will be important for our next presentation, where we talk a little bit more about Langerhans cell histiocytosis. Thank you for listening to my intricacies.
Thank you, Erica. That was a lot of information packed in the few minutes you presented. Next on, we'll have Tines back. Dr. Diggs is going to go through the classification of histiocytic and dendritic cell tumors. Now we're getting closer to the clinical stuff now. So yeah, over to you, Tines.
Thanks, thank you so much, Prof. So as Prof said, we will be looking at the MPS system and how we classify the tumors, and specifically this talk will be on the tumors originating, but perhaps more importantly, the tumors differentiating to mononuclear phagocyte system cells. So perhaps with these cells, as with humans, it's maybe a bit more important what you turn into than where you come from, but I'll get more to that a bit later. So in the World Health Organization, the Blue Book 4th Revised Edition, these tumors were separated into two groups. We had blastic plasmacytoid dendritic cell neoplasms that were part of their own group. And then at the end of the book, in chapter 17, we had the histiocytic and dendritic cell neoplasms. And something that I will mention, and Erica just did mention this in her talk, that histiocytes, for the purposes of the WHO, are considered synonymous with macrophages. So when they say histiocytes, what they're actually referring to are macrophages. Then along came the WHO-5, and a few changes were made. First off, the two groups were combined. So blastic plasmacytoid dendritic cell neoplasms and the rest of the histiocytic and dendritic cell neoplasms were combined into one group, chapter 3. What's interesting is this chapter follows the myeloid proliferative diseases. So maybe there's some hint there from the committee who wrote the WHO-5 that there might be a closer link to myeloid of histiocytic neoplasms to myeloid neoplasms than to lymphoids. But I'll mention a bit more about that at the end. The follicular dendritic cell sarcoma and fibroblastic reticular cell tumors, these were removed in the new classification of the WHO. And this is really because we understand that their origin, or they were removed away from this group and into a group called tumors of stromal origin, still within the WHO-5. But we just realized that these cells don't have their true home in histiocytic and dendritic cell neoplasms. As Erica explained, that dendritic cells are not true dendritic cells in the way that we understand them today. There were a few new entities added, so the first of which would be mature plasmacytoid dendritic cell proliferation that are associated with myeloid neoplasms. And then in the macrophage neoplasm group, two diseases, Rosai-Dorf 1 and ALK-positive histiocytosis, were added. So let's start off perhaps with a tumor that's a bit more familiar to everyone. That would be blastic plasmacytoid dendritic cell neoplasm. So when we talk about these chapters, we really are speaking about this group here. So the plasmacytoid dendritic cells and tumors that originate from these cells. So this is a neoplasm of immature cells with the plasmacytoid dendritic cell differentiation. Classically, this is a disease that will present in male patients of around 70 years, and you have both cutaneous involvement and systemic dissemination of the disease. So typically, both a rash or some sort of skin lesion, as well as systemic symptoms. About a quarter of patients with blastic plasmacytoid dendritic cell neoplasm have some associated NDS or NPM-NDS, again, kind of alluding to more of a myeloid origin of these cells, but again, that is just speculation. The MDS can also be attributed to the complex karyotype that we classically see in these conditions. Specifically, there are mutated epigenetic genes, mutations in the spliceosome, and genes that regulate your cell cycle, specifically the G1 to S phase genes. The immunophenotype of these cells is what's kind of, if you're studying at least, can be remembered by 1, 2, 3, 4, 5, 6. So 1, 2, 3 being the interleukin 3 receptor, and then aberrant expression of CD4 and CD56, which make up the 1, 2, 3, 4, 5, 6. TCF4, Erica mentioned, is kind of the master regulator of plasmacytoid dendritic cell differentiation. And we also spoke about the blood dendritic cell antigens, CD303 and CD304. Importantly, these cells don't have any other lineage markers, and they are usually negative for CD34, which is a bit strange when we look at the name blastic plasmacytoid dendritic cell neoplasms. Overall, unfortunately, the outcome of these diseases are quite poor. There are various ways to treat them. You can treat them as an AML or more like an ALL. A new targeted therapy that can be used for them is tagraxofusp. So this is a IL-3 that has been fused with diphtheria toxin. And if you realize that this CD123 that's present on these cells is indeed the receptor for interleukin 3, it makes sense why this has been used as a targeted therapy. Otherwise, aim for allo stem cell transplant in first remission in these patients. The morphology of these cells can be a bit varied, but generally speaking, you have medium to large cells, and they have this interesting cytoplasm that seems to almost want to bud off or slide off. To me, it's kind of reminiscent of the videos of people going into zero gravity or astronauts flying, and you have this water droplet that's flowing. So you can see here, for example, the cytoplasmic tail that wants to form, and the tiny little bubbles that kind of represent the vacuoles in the cytoplasm of these cells. This is just my way of remembering what the morphology looks like. I don't think this is in any textbook, but you're welcome to use that if you think that will help you. Please note that these cells don't always look like this, but it's a good general idea just to have in mind when you see cells like this on your aspirate of a patient. Moving along now to the new addition to this category, which would be the mature plasmacytoid dendritic cell proliferations. So this is a clonal proliferation of dendritic cells that are associated with some sort of myeloid neoplasm. CMML, so chronic myelomonocytic leukemia is classic one, specifically those with the RAS pathway mutations. And up to 5% of AMLs have this mature plasmacytoid dendritic cell proliferation happening in the background. It seems to be the same clone as AML, but there is transdifferentiation happening. With transdifferentiation, what we are saying is there's a cell of one lineage or one cell type that's crossing over to another cell lineage or cell type without going back to a pluripotent stem cell phase. So it's kind of a horizontal progression of the clone. And you can see a spectrum of plasmacytoid dendritic cells in these patients. So you can see the more immature forms, so these will be CD34 positive, CD303 will be dim. To the more mature forms, where CD34 will be negative, and CD303 will be expressed brighter. you have your classic immunophenotype that we associate with plasmacytoid dendritic cells. However, there can be aberrant loss of some of these markers, in particular CD303 and TCL1. What's very important and nice to note in these cases is they aberrantly express CD34 in a lot of the cases. So this would be the immature plasmacytoid dendritic cells that we are speaking of. And when you think about a mature plasmacytoid neoplasm, you wouldn't automatically think that CD34 would be positive, but that is something just to note. As the occur of myeloid neoplasms, unfortunately, the presence of mature plasmacytoid dendritic cell proliferation is associated with a poorer prognosis than what the myeloid neoplasm would originally carry. And it's also important just to note that these diseases associated with myeloid neoplasms are not the same as some of the plasmacytoid dendritic cells that we see in SLE and Castleman's that are reactive and are not clonal proliferation. So this would not qualify as MPDCP. If we look at the morphology here, like I said, you can maybe appreciate the two different types of cells. So you have a classic blast here, so this will probably be your myeloid neoplasm, medium-sized cell, less mature chromatin. And here, maybe you can imagine the plasmacytoid dendritic cell, bit more mature looking cell, chromatin, a bit more mature. And you can see the same throughout the spectrum here. Classically a blast, and then another cell that's also looking atypical, but more mature than the blast than you would expect. And this is just another image showing how, even though you can have the vacuoles, the cytoplasm looks a little bit different to those of the blastic variant, and your vacuoles can be more prominent, although they vary. And it is very important to consider these conditions, as in all conditions, in a clinical context, and what you are seeing on immunohistochemistry or flow cytometry. So that is the first group done, so the tumors derived from plasmacytoid dendritic cells. The next group that we're going to look at are the Langerhans cell and other dendritic cell neoplasms. So when we talk about Langerhans cell, like Erika mentioned, we're really kind of thinking now that this is the group that these cells are originating from, your conventional dendritic cell 1 and conventional dendritic cell 2. These tumors do not seem to be derived from macrophages, which were originally from yolk sac or fetal liver origin, but rather cells that came from the hematopoietic stem cell in the bone marrow niche. So when we talk about the Langerhans cell, we're talking about an embryonically derived macrophage that's resident in the epidermis. But when we talk about Langerhans cell histiocytosis, it's rather a clonal neoplasm of this bone marrow cell that just so happens to have the immunophenotype of a Langerhans cell, which would classically be CD1A, S100, and CD207, which is also called Langerhans. The reason for this classification is probably because when these cells were discovered, Langerhans or Burbeck granules were seen as very specific for your Langerhans cells. However, as Erika alluded to, other cells in the dermis can have Langerhans positivity. And I think that's part of the reason why this classification has evolved. And now we're thinking possibly it's a conventional dendritic cell that is the origin of these tumors. You get two different types, broadly speaking, in terms of clinical presentation. You get a single system LCH. This is usually seen in your older children and adults. They present with a rash with multiple osteolytic lesions and pituitary dysfunction that will classically manifest as diabetes insipidus. You also get multi-system LTH. This is more like the case that was presented at the beginning of the talk. So here you have multiple bony lesions, which we had in our patient. We have a soft tissue mass in our patient that was causing a proptosis, and we have the rash. These rashes can often be misdiagnosed as a sort of allergic rash or allergic dermatitis. So it is important to bear that in mind when you're seeing a patient with an atypical presentation of a rash, maybe with some systemic symptoms. Langerhans cell histiocytosis can follow a lot of your lymphoid malignancies, so follicular lymphoma or ALL can be a preceding disease or a concurrent disease in these conditions. And there's also an association with Erdheim-Chester, which we'll mention at the end of this talk. The MAPK pathway is usually mutated in Langerhans cell histiocytosis, specifically BRAF V600E, which is the same mutation that we see in hairy cell leukemia can be affected, as well as other genes such as the MAP2K gene. If we look just quickly again at the morphology and immunohistochemistry, we did mention that these cells will be positive for Langerhans cell markers, so CD207, Langerhans, CD1A, and S100A. Other markers like fashion and factor 13, sorry, this should read factor 13, which are more associated with macrophages, are often negative. Just looking at the morphology again on H&E, this is a nice image from an alveolar lung infiltrate of Langerhans cell histiocytosis. And again, I just want you to appreciate the voluminous pale pink cytoplasm of these cells. And here you can nicely see the grooves that are running through the nucleus of a lot of these cells. And you can also appreciate the inflammatory infiltrate as exhibited here by the eosinophils, which you can see. As the disease progresses, there's usually more fibrosis and your cell population becomes less, and you might not be able to appreciate the Langerhans cells or the inflammatory infiltrate of eosinophils and other cells as nicely. The last three conditions in this group I put together on one slide, just quickly run through and contrast them a little bit. These are very rare tumors, but I think it is important for completeness sake to just mention them. So Langerhans cell sarcoma, this is usually a disease that's found in adults with an extranodal presentation, and these are relatively high-grade tumors. They seem to be like Langerhans cell histiocytosis with a similar immunophenotype. However, the high-grade kind of makes you think that these are tumors that have gone one step further and have lost kind of their normal cytology. This can be a difficult condition to diagnose based on cytology alone. If Langerhans cell sarcoma represents one step forward, then indeterminate dendritic cell tumor perhaps represents one step back. So here we only have CD1A being positive. We don't have the CD207 or the Langerhans being positive in these cells. And the thinking is that if this is a type of Langerhans cell, dendritic cell, that it's probably just a stage earlier, that it hasn't committed to the Langerhans cell phenotype quite yet. But we really aren't sure what the ontogeny of these group of cells are. You don't have the lytic lesions that you see in Langerhans cell histiocytosis. You don't have pituitary dysfunction, although these diseases can be associated with lymphoid or myeloid malignancies. The final group are the interdigitating dendritic cell sarcomas. Interdigitating dendritic cells are a group of dendritic cells that are classically associated with tissues with a lot of T cells, so the thymus would be one. And they are named interdigitating dendritic cell sarcomas because of the immunophenotype that's similar to these interdigitating cells. But we don't think their cell of origin is truly the interdigitating dendritic cells. Presentation can be nodal or extranodal. Your Langerhans cell markers are negative. You don't have any markers of follicular dendritic cells. And then other than the S100, your melanocytic markers will be negative. Often in these tumors, it's important to differentiate, are you dealing with a melanoma that's infiltrating the skin or the nodes, or if it is some sort of dendritic cell sarcoma, but these would be negative for those markers. Right, so the final big group that we're going to look at would be the macrophage neoplasms, and the first of these would be juvenile xanthogranuloma. Now, when we speak about these conditions, we think that they are coming from our monocyte-derived cells, so monocyte-derived dendritic cells, macrophage type 1 and macrophage type 2 or M1 and M2. Although we're not quite sure yet, but we think it's unlikely that they come from these yolk sac and liver, fetal liver-derived macrophages that you can see here on the left. So these cells typically take on a dermal macrophage phenotype. They are generally confined to the skin. They appear in younger patients that are less than 15 years of age, generally speaking, hence a juvenile. And the xanthogranuloma just refers to the collection of macrophages or the granuloma that forms in these cells that have a yellowish color, xantho meaning yellow, and that would be because of the lipids that are within these macrophages. This condition typically presents with focal lytic bone lesions, And your immunophenotype would be that of macrophages along with factor 13A and fashion. You'll be negative for your long-run cell markers. You'll be negative for ALK, so thus explaining diagnosis of ALK-positive histiocytosis. And your S100 may be positive in these cells. The cousin of this first condition, kind of in older people, would be Erdheim-Chester disease. So this neoplasm is characterized by a lot of mature foamy macrophages or histiocytes that are collecting together. And this is in young adults or older people that get this disease. In contrast to the focal lytic lesions that you see with xanthogranuloma, you see symmetrical sclerotic lesions. These will typically happen on the long bones. So if on your CT scan you're seeing symmetrical lesions, then think towards Erdheim-Chester. However, this disease can affect many different organs. So the kidneys and the heart are classic examples. And we're not really sure what the origin of this disease is, what the cell of origin is either. We think it might be myeloid, but we're not sure. The myeloid origin mainly comes from its association with a CMML in about 15% of cases. And as mentioned, it can be present with lung-run cell histiocytosis. Frequently, you see two-tone giant cells in these cases. So you can see some exhibited here on the right, kind of a foamy periphery of an area of more centrally located nuclei that are located in a ring, and then this homogeneous pink central zone that you can appreciate. The immunophenotype is similar to juvenile xanthogranuloma, but the S100 is typically negative in these patients. And again, you see the BRAF mutations coming up in this group of diseases. Erdheim-Chester was also the subject of an episode of House, MD, early in season 2. He had a young boy who was having non-specific symptoms. This is a bit different to what we know today. The patient that presented was a young boy with neurological symptoms and gastro symptoms as well. GIT symptoms can be a presentation of these patients, typically seen in older patients, and typically your symmetric sclerotic bone lesions on your biopsy will guide your diagnosis. So if we had a group of mainly S100 negative neoplasms, if you have an S100 positive macrophage, you're thinking along the lines of Rosai-Dorfman disease. So there are different types of Rosai-Dorfman. You can get nodal presentation, extranodal, as well as familial types, and those related to immune system dysregulation or other neoplasms. This seems to be more common in African descent, at least in one study that looked at the disease incidence in African Americans. And what you can see on morphology are cells with prominent nucleoli, abundant cytoplasm with lots of vacuoles, and characteristically, you have emperipolesis. So you can see there are some cells here that are trafficking through the cytoplasm of the cell. This is different to phagocytosis. They are just moving through. And this is a very characteristic feature of Rosai-Dorfman disease. If you stain these cells with S100 on immunohistochemistry, your emperipolesis will highlight nicely, as well as your macrophages. These cells will have some sort of macrophage or histiocytic marker. CD68 would be a classic one, and then negative for your long-run cell markers. The last two diseases that we'll discuss today would be ALK-positive histiocytosis and histiocytic sarcoma. So ALK-positive histiocytosis is a non-high-grade cytological tumor. So this is to differentiate it from other ALK-positive tumors that we know, such as anaplastic large cell lymphoma. Here you have a fusion with the ALK gene, characteristically with the KIP5B gene on chromosome 10. And as such, as it is this fusion that's driving the disease, these diseases will be BRAF negative. While they are very rare, it is interesting to note that you have a female predisposition here, and in all the other diseases that we've discussed, is predominantly a male predisposition. You just need two histiocytic markers and the outcome of, and the ALK fusion to diagnose this disease. Another fairly vague entity, and last one we'll discuss, is histiocytic sarcoma. So this presents on histology as a group of non-cohesive large cells, frequently associated with something like CLL. and you have one or more macrophage markers, but you don't have any markers that are specific for Langerhans cell, like a CD1A. You don't have follicular dendritic cell markers, which would be CD21 or CD35, and you don't have myeloid markers present in these cases. And interestingly, if you try and do a literature search, you'll see it's quite common in our canine friends, and definitely more common in them than these neoplasms are in humans. Finally, I just want to draw your attention to the Histiocyte Society. So they have a different way of classifying these groups. So they classify them into an L group, into an M group, a C group, a T group, and an E group. What's interesting here is that while they focus a bit less on ontogeny, they are more focused on grouping disease per presentation, and they also include the non-malignant diseases of macrophages in this category. So just some final thoughts on the ontogeny and how it relates to the classification in the new WHO. It's nice to see that the WHO5 is using the current way of thinking to broadly classify our histiocyte and dendritic cell neoplasms. There's a fair bit of trans-differentiation within this group. It's interesting that even though your plasmacytoid cells are plasmacytoid in morphology, and they're associated with viral immunity, they're more, and they have a common lymphoid progenitor in some theories, they're more associated with myeloid cancers than with lymphoid cancers. And your conventional dendritic cells, again, are more associated with concurrent or antecedent lymphoid cancers. These disorders can also occur in each other. Classically, Langerhans cell histiocytosis, Neuromanchester disease can occur together. The ICC, which is the other classification system that we sometimes use, puts this chapter on macrophage and dendritic cell neoplasms after the mature lymphoid neoplasms. And perhaps this is their way of saying they kind of think this group is more related to lymphoid cells in origin, possibly because of the MAPK pathway activation that we see in these diseases, similar to what we see in hairy cell leukemia. But that's just speculation from my part, to be honest. And then finally, the Histiocytic Society, which we looked at last, as a classification for both on malignant and on benign lesions in these disorders. Thank you very much for your time. I hope we shed some light on the ontogeny of these cells and how it relates to their classification. And hopefully, when someone mentions Erdheim-Chester, you won't be running for the hills. Thank you.
Thank you, Tines. Very comprehensive. I followed every word. So just to recap, we had Tines shooting off with the case presentation. Then we went through the ontogeny and now the classification of the tumors. I do not see any questions. I see two comments. One from Professor Estelle Verberg and the other one from Professor Jessica Opie. The operative word is brilliant, and that's directed at Erica. Well done. I see there we also just have excellent presentation for Mainolia Naidu, Gary Claudine. Need to watch this again. I agree. You need to go through this again. It was a lot condensed in lecture. So perhaps Erica and Tines, you want to tell us if these are going to be available, when are they going to be available? So people can have a good look piecemeal. And then there's another one from Dr. Ramia, Jasmine Ramia, saying. Are there any questions from the, I see Estelle, your hand is up. Please unmute and speak.
Yes. Wow. I think this is absolutely brilliant. Both talks. That's a fact. And we enjoyed it immensely. I think that I can speak for everybody. I think it's really quite an important topic for all of us. Just regarding the last part of the classification, we really like in the clinical side, and I'm sure that's what the lab side also shows us, we truly like to try and focus when we do clinics. As you know, we try to put patients into registries and diagnostics. We focus on approaches. And that's what I like so much about the WHO Hem5. Obviously, it's been there from the beginning, you know, from the real classification until now. But this whole approach, and it's truly fascinating to think where all the diseases are now going to fit and how we are going to, you know, wed the benign and malignant stuff together. What's also fascinating, as Tinus has shown, is that there's now, for example, Rosé-Dorfman that's coming in. There's different things, IG4, like that's now a different, you know, area. But there's different lymphoid proliferations. There's all kind of stuff coming in. Even our favorite old cold agglutinin disease that comes into the malignant stuff. So this is just brilliant. I hope it's not the last we hear of it. I just really, really loved it. I think everybody that loves the study of blood must love such a talk.
Thank you very much. I see more comments there. Jack Marheb says, I couldn't read that. A big one has come through. Jack, do you want to unmute and maybe speak? Dr. Malherbe?
Yes, we just a really fascinating talk. I just incidentally reviewed a patient in the clinic today with we diagnosed a couple of years ago with really struggled with the diagnosis. It made it a MDS-MPN overlap syndrome that didn't really fit any clear category. She's got splenomegaly and some monocytosis, but doesn't fulfill the criteria of CMML, and on NGS she had quite a large KRAS mutation clone, and elderly lady, actually apart from my mild cytopenia, is not requiring any specific therapy. And then recently she developed skin lesions on her calves, which was initially biopsied and pathology diagnosis of melanoma, and then went for surgery and plastic surgery, and she had satellite lesions which they re-biopsied, and then pathology reviewed the histology, original histology and the current histology, and made it a histiocytic type tumor with quite a broad differential. So I was just actually wondering about one of these new entities, and the link that it was just interesting that I reviewed this patient in the clinic today, and then we talk about this. I just found it quite a fascinating talk. So thanks.
Thanks, Jack. I'm sure Yaku and them will be able to maybe re-examine and come up with a more appropriate classification. Are there any more questions at this point? Please just unmute and speak. And Erica and Tinus, if you have any clarifiers or comments, just go ahead and unmute and speak, please.
Thanks, Frank. I'll just make a comment. And the reason for this deep dive was, one, because we must guide our young registrars and let them know what chapters of mechanisms are unreliable. And the second one was it stemmed from this WHO5, and I did my own deep dive when I read a sentence saying Langerhans cell histiocytosis comes from a dendritic cell precursor, and I was like, what is going on here? And it was a whole can of worms that I opened up for myself, and I hope that I have just hopefully stimulated some other people also just to keep up to date with things that we think are already really sorted, like not even ontogeny is sorted with dendritic cells and macrophages. So yeah, watch the space.
Any more comments, questions, anyone? We have some good words for both Tinus and Erica from Charlene Parasnak in KZN, our own Helena Cornelissen, our own Kesh, and Michael Lindstrom. Any more questions or comments, please unmute and speak. It looks like everyone is happy. Estelle, what do? Do we say goodbye?
Yes, we say goodbye and have a lovely afternoon. And thank you, Tygerberg. Thank you, Stellenbosch University.
Thank you, everyone, and have a good evening. We'll see you soon.
Yeah, have a good evening.